This is the Video Journal of Orthopedic Surgery, with our moderator, the professor and chairman of the Department of Orthopedic Surgery at the Medical University of South Carolina, Dr. John B. McGinty.
In this issue of the journal, our speakers are, from Rochester, New York, Dr. Kenneth E. DeHaven, professor of orthopedic surgery and head of the section of athletic medicine at the University of Rochester School of Medicine. From Portland, Oregon, Dr. Stanley L. James, assistant clinical professor of surgery, Division of Orthopedics and Rehabilitation, Oregon Health Science University. From Sacramento, California, Dr. Michael W. Chapman, professor and chairman of the Department of Orthopedic Surgery at the University of California at Davis. And from Columbus, Georgia, Dr. James R. Andrews, clinical professor of orthopedic surgery at Tulane University School of Medicine and director of orthopedic training at the Houston Orthopedic Clinic. We will begin with Dr. Andrews, who will discuss arthroscopy of the shoulder. We all know the progress of arthroscopy of the knee in the past decade. Tell me, where has arthroscopy taken us in the shoulder?
Jack, we've taken what we've learned from knee arthroscopy and we've applied it directly to the shoulder. We're using our same manual techniques to the shoulder joint. We're using the same type of instruments we use in the knee for the shoulder, and it's been a natural evolution to move from the knee to shoulder arthroscopy. My experience with operative arthroscopy of the shoulder includes 396 cases in 392 patients. 343 of them are male and 49 are female. The average age is 27.1 years. 283 of these cases have been done in athletes, most of them in baseball players, 172, with 119 of them being pitchers and 81 of them being professionals. Other sports include 111 patients. The pathology concerned with operative arthroscopy of the shoulder in my series includes labrum tears, 269, partial rotator cuff tears, 187, biceps tendonitis, 26, partial avulsion biceps, 32, rheumatoid synovitis, 13, intra-articular adhesions, 14, and loose bodies, 10. Let's first discuss the general setup for shoulder arthroscopy. We're in the arthroscopic suite and the patient is lying in the left lateral decubitus position with the right arm suspended by prefabricated wrist gauntlet to a manufactured shoulder holder. 15 pounds of traction is applied with the arm in 70 degrees of abduction and 15 degrees of forward flexion. A routine sterile prep and drape is done using arthroscopic draping techniques. We'll identify the posterior lateral tip of the acromion. We'll move 3 centimeters from the posterior lateral tip at the midline posteriorly of the glenohumeral joint, and we'll enter with an 18-gauge needle. We'll then instill about 40 cc's of sterile saline into the shoulder joint, which confirms our entry into that joint. We then will remove the 18-gauge needle and use an 11-blade scalpel to make a small skin laceration, and then introduce a sharp to blunt obturator cannula system, and then introduce a 4mm 30-degree angled arthroscope, the same arthroscope that we would use for knee surgery. The arthroscope is attached to a video system, and the intra-articular anatomy is viewed on the monitor as seen in the left upper quadrant. This happens to be a professional baseball pitcher, and immediately we're picking up the intra-articular pathology involving his glenoid labrum. A systematic check in the right shoulder going in a clockwise fashion is first done. We're viewing this directly off the monitor in the background. A second portal is done. This is an anterior portal which is placed between the coracoid process and the anterior lateral tip of the acromion. This actually enters the shoulder through the coracoacromial ligament, a safe area to enter the joint. As you watch here in the upper quadrant, we enter with the needle in the soft spot between the supraspinatus portion of the rotator cuff and the subscapularis tendon. We'll then penetrate with a sharp scalpel, making a skin laceration, and then introduce a sharp to blunt obturator cannula system to set up an inflow cannula into the anterior aspect of the shoulder joint. Distension is extremely important for visualization with shoulder arthroscopy. It helps to control hemorrhage and blows the shoulder up, distends it so that we can get good visualization. Our inflow is now attached to the anterior cannula. With that cannula in place, we'll use it to palpate the normal intra-articular anatomy of the shoulder joint. Next, we'll establish a second anterior portal for operating instruments. This is done again by using an 18-gauge needle to establish under direct visualization with the arthroscope the second anterior portal. It's placed close to the first anterior portal and again passes between the coracoid process and the anterior lateral tip of the acromion. A sharp to blunt obturator cannula system then penetrates the soft spot near the biceps tendon in the anterior capsule of the shoulder joint. This shows a motorized operating instrument being delivered down the cannula for intraoperative arthroscopic work. We're now debriding a portion of the torn anterior glenoid labrum and viewing the process on the monitor in front of the patient. Quite frequently, it's necessary to switch from back to front. This shows us switching the arthroscope to the anterior cannula and looking from the anterior toward the posterior aspect of the shoulder, using our motorized operating instrument to debride a portion of the posterior glenoid labrum. Let's now review the normal arthroscopic shoulder anatomy as seen with the arthroscope from the posterior of a right shoulder. This graphic first illustrates the biceps tendon labrum complex, which is a primary landmark in the shoulder, particularly after first entering the joint. This is a right shoulder. The arthroscope has been introduced through the posterior portal, and we're looking at the biceps tendon as it inserts through the superior labrum to the superior aspect of the glenoid. This is a constant anatomic landmark. We'll go back to the biceps tendon again as we look as it exits out of the shoulder joint through the bicipital groove. We pull away and look down again on the biceps tendon labrum complex as it inserts to the superior labrum. Remember, this is a right shoulder. The arthroscope has been introduced posteriorly, and we're looking toward the anterior aspect of the shoulder with the biceps tendon in the background, the rotator cuff above, the humeral head to your right. We'll next try to focus in on the anterior glenoid labrum and the middle and inferior glenohumeral ligaments. This shows the anterior superior glenoid labrum, and we slip up the biceps tendon, look out the bicipital groove. We look toward the anterior aspect of the shoulder, and in the background with the arrow is the oblique edge of the subscapularis tendon. This shows the anterior glenoid labrum with the middle glenohumeral ligament passing off of the labrum into the background. This is the bursa, or the opening into the subscapularis bursa we're looking into. There's the anterior superior labrum. We'll now focus on the anterior and inferior glenoid labrum and the anterior inferior glenohumeral ligament. We have to distract the humeral head a little bit. We look down, and here's the 5 and 6 o'clock position demonstrating the anterior and inferior glenoid labrum with the inferior glenohumeral ligament blending off into the inferior capsule as seen by the arrow. Once again, distract. Inferior glenohumeral ligament in the background, blending into the inferior capsule. We're coming now back across the back of the humeral head, looking back toward the superior portion of the glenohumeral joint. getting a good view of the posterior aspect of the humeral head itself. We're looking down now on the glenoid surface with the posterior and inferior glenoid visible directly in front of the camera. This shows back around to the 11 o'clock position, back to our old friend, the biceps tendon labrum complex. This shows a sweep back across the humerus, the non-articulated portion of the humeral head, which is normal. Here's the articulated portion below. This is not a Hill-Sachs lesion. This is a normal anatomy of the back of the humeral head. This is a teres minor portion of the rotator cuff, infraspinatus, and back around to the supraspinatus portion of the rotator cuff, thus illustrating very well from the posterior portal the normal arthroscopic anatomy of the shoulder joint. Let's go back now and review this normal arthroscopic anatomy from the graphics. This first graphic highlights the biceps tendon labrum complex. This is a right shoulder. It's a bird's eye view looking down on the glenoid. And here's the biceps tendon as it enters the shoulder joint and blends into the superior labrum. Notice how strongly it blends into actually the posterior superior labrum. This actually then inserts, as you well know, to the bony area of the superior glenoid itself. Blending from the front of the biceps tendon is the anterior superior labrum with its superior glenohumeral ligament being held by the forceps in the background as indicated by the arrow. And this is highlighted to demonstrate the anterior-inferior glenoid labrum itself. Notice the inferior capsule as it blends off into the inferior aspect of the shoulder joint. In the upper portion of the highlight, again, is the anterior-inferior glenohumeral ligament, which is the primary stabilizer against anterior instability of the shoulder joint. With the normal anatomy in mind, let's now look at some of the pathology seen arthroscopically in the shoulder joint. The first case is a labrum tear involving the anterior superior portion of the glenoid labrum. We're looking in a right shoulder from the posterior, and you're looking directly at the anterior superior labrum, which has been detached from the front of the glenoid. Notice the humeral head in your right upper quadrant. Notice the fluffy tearing of the anterior superior labrum as it blends into the biceps tendon, which can be seen in the background. This is a typical tear, particularly seen in throwing athletes involving the anterior superior labrum in a right shoulder. We're now going down into the 4, 5, and 6 o'clock position, and that portion of the labrum is actually intact. To continue with pathology of the labrum, this next case is a superior biceps tendon labrum complex tear. We're in a right shoulder again with our arthroscope placed posteriorly. We're using the inflow cannula to palpate a bucket handle tear of the superior glenoid labrum. Notice that this is displaceable. This is a common lesion involving the biceps tendon labrum complex as seen quite frequently in the throwing athlete. Pathology. Let's talk about the unstable shoulder. This is a right shoulder. Again, we're looking at the biceps tendon labrum complex, and you can see that the superior labrum has been ripped off with a portion actually involving the biceps tendon itself. We'll look closer at this and find out that this labrum tear actually extends down into the anterior labrum and is consistent with anterior recurrent dislocation of the shoulder. Notice here the large Hill-Sachs lesion on the back of the humeral head. Here's a defect right here. We place the scope now anteriorly, and we're looking toward the anterior part of the glenoid, and you'll see that the glenoid labrum has been completely detached from the front of the glenoid, thus producing a Bankart type lesion. Let's go to the rotator cuff and discuss partial thickness tears. This is a right shoulder, and we're looking in from the posterior, and we're using an inflow cannula to palpate the supraspinatus portion of this rotator cuff. This gives us a little better view. As we sweep around, you'll again see a flap tear involving the supraspinatus portion of the rotator cuff. We're using the inflow cannula to demonstrate its partial thickness. That was a typical partial thickness tear as seen in the throwing athlete. We'll next discuss the rotator cuff tear that goes from partial to full thickness. This is a right shoulder. The arthroscope is through the posterior portal, and we're now looking again at the area of the supraspinatus portion of the rotator cuff, and you see the fraying of the rotator cuff, the inflow cannula again demonstrating the partial thickness tear, perhaps full thickness tear in this particular position. It's very difficult arthroscopically sometimes to tell whether these things are actually partial thickness or full thickness. Quite frequently they have cleavage planes, and what appears to be partial thickness will actually be full thickness type tear. Certainly in this case, there's extensive damage to the rotator cuff. The next case is a full thickness rotator cuff tear. The arthroscope has been placed posteriorly, and we're looking into the shoulder joint at the humeral head and up at the area of the supraspinatus attachment of the rotator cuff to the greater tuberosity. This depicts a full thickness tear. Actually, the arthroscope can be passed out through the full thickness tear, and you can look up at the subdeltoid bursa in the background. This represents a rather massive rotator cuff tear. The biceps tendon can also be torn. This is a right shoulder. We're looking in from the posterior with the arthroscope. We're looking directly at the biceps tendon, showing the shredding of its intra-articular portion. The inflow cannula is used to palpate it and to demonstrate how it's torn up and shredded from deceleration forces in the throwing act. From an arthroscopic surgical standpoint, let's see what we'll do about some of these lesions. We'll start with labrum tears. This is a right shoulder. We're looking in again from the posterior. We're using the inflow cannula to demonstrate the superior bucket handle tear of the glenoid labrum. This labrum tear is displaceable. I brought in an arthroscopic knife, and I'm going to detach the anterior superior portion of it. We'll try to take out as much of this labrum in one segment as possible. Again, the knife is then passed posteriorly, superiorly, and the posterior superior portion of it is detached, and then the free fragment is grabbed with a clamp and delivered from the shoulder joint through the anterior portal. We'll then bring in a motorized operating instrument, a full radius resector, and smooth the edges of the superior labrum. This shows the completion of the procedure. Arthroscopic surgery, biceps tendon labrum complex tear. This is a Major League Baseball pitcher, and it demonstrates the biceps tendon labrum complex tear involving the biceps tendon and the superior labrum. The inflow cannula is being used to demonstrate the considerable shredding of the biceps tendon, that is, its intra-articular portion. We now brought in a motorized instrument, and we're debriding the shredded and torn superior labrum, both in its anterior superior portion as well as its posterior superior portion. Debridement of this tissue, particularly in the elite throwing athlete, has been very successful. This shows the completion of the debridement of the anterior labrum. The biceps tendon itself was also debrided. Arthroscopic surgery, rotator cuff tear. This is a right shoulder, and we're using the inflow cannula to palpate the rotator cuff tear involving the supraspinatus. This is a typical rotator cuff tear as seen in the elite throwing athlete, again occurring during the deceleration phase of throwing. We're now using a motorized operating instrument to debride the supraspinatus portion of the cuff. Hopefully this debridement will increase the blood supply and promote a proliferative healing response for this rotator cuff. As you can see, this is a partial thickness tear. We're now smoothing out the edges, and we're actually seeing some blood supply in the background. We're now looking in from the anterior. The arthroscope has been placed through a posterior portal, and we're completing the debridement of this cuff tear, which actually extends back into the infraspinatus region. We're using a full radius resector here to smooth out the edges. Let's next discuss the anteriorly unstable shoulder. This is a right shoulder, and we're going to demonstrate a stapling technique for anterior recurrent subluxation of the shoulder. You'll notice that our motorized instrument is in through an anterior portal, and we're cleaning the front of the shoulder of the soft tissue. We're trying to demonstrate here with a blunt obturator that the anterior glenoid labrum can be reduced to the front of the glenoid. Notice that I am using the assistant to reduce the shoulder back into the normal position. The next step in the technique is to use a motorized burr to burr the front of the glenoid so that the capsule and anterior glenoid labrum will stick down and heal to bone. This shows a close-up view of the burr burring down to raw bone on the front of the glenoid. This is the arthroscopic instrumentation for stapling. We're introducing a small arthroscopic staple through a cannula through the anterior portal of the shoulder joint. The staple has been introduced around the glenoid labrum and anterior capsule, and the staple will next be driven into place in the anterior superior portion of the glenoid. We're using a hammer, and we'll drive the staple into the anterior glenoid, thus reapproximating the anterior capsule and glenohumeral ligaments to the front of the glenoid. The impactor is then removed, and the insert shows the staple in place with the approximation of the glenohumeral ligaments to the front of the glenoid. This is another view showing how the anterior capsule and glenohumeral ligaments have been approximated, thus stabilizing the shoulder joint. We'll now talk about the unstable shoulder posteriorly. This is the left shoulder, and we're looking in from an anterior portal at a posterior Bankart type lesion. This is a college baseball player who has a posterior subluxation of his shoulder. A motorized operating instrument has been introduced through a posterior portal, and we're detaching the soft tissue and cleaning the soft tissue from the back of the posterior glenoid. We're going to use a stapling technique to stabilize the posterior glenoid labrum and posterior capsule back to the glenoid itself. We're using the burr, again, to get down to raw bone on the back side of the glenoid. This will promote our healing. Once we've set the soft tissue up in the bone, we'll then bring in an arthroscopic staple and restaple the posterior glenoid labrum and posterior capsule back to the posterior aspect of the glenoid. This shows the arthroscopic staple being delivered, the two prongs of it under direct visualization, reapproximating the posterior glenoid back down to the posterior glenoid itself. Staple has now been driven into place, and the impactor will be removed. This is the post-operative arthroscopic view following the placement of the staple. Throer's exostosis is the development of an osteophyte on the posterior and inferior aspect of the glenoid, commonly seen in the older throwing athletes. This is an arthroscopic view from the posterior and the left shoulder, and it shows an articular cartilage lesion associated with this Throer's exostosis. The arthroscope is now placed from an anterior portal, and we're looking down on the posterior and inferior part of the glenoid labrum, and beneath the soft tissue is the exostosis. To see this exostosis on the posterior inferior aspect of the glenoid, you must bring in a full radius resector and resect the soft tissue and partially resect the capsule off of it. As we do this, the bony exostosis associated with the throwing act is readily demonstrated. We're now using a motorized burr to actually debride a portion of the spur itself. The spur was so large along the posterior aspect of the glenoid that we next brought in an arthroscopic chisel and actually chiseled away a portion of this exostosis. This shows the loosening of the major portion of the exostosis. We're still using the chisel to loosen it. We'll then come in with a Schlesinger clamp and extract the major portion of this bony exostosis. We'll then use a full radius resector to further debride the soft tissue, smoothing up the bed where the exostosis has been removed. You'll see here that we're trying with the burr to finally get the level of the exostosis down below the articular margin of the glenoid. There are some specialized areas of shoulder arthroscopy that I'd like to cover. First is arthroscopic acromioplasty. This is a right shoulder, and we have the arthroscope placed through a posterior portal, and we're going to look at the rotator cuff in this 60-year-old gentleman who has previously refused open rotator cuff repair. The inflow cannula readily depicts the frayed, torn edges of the supraspinatus portion of his rotator cuff. This obviously is a very significant rotator cuff tear. We're using a full radius resector to debride the undersurface of this rotator cuff. This probably represents a full thickness tear. We're looking in from the anterior and we're debriding the posterior part of the rotator cuff. This shows the completion of our debridement. It's very important in these cases to go to the subdeltoid bursa and take a look at the outside of the rotator cuff. We use the same portals, one anterior and one posterior, to redirect our cannulas into the subdeltoid bursa beneath the acromion. A large bore inflow cannula is used for inflow, and a regular cannula is used for the 4 millimeter 30-degree angle arthroscope. The inflow is now established to the anterior cannula, and you'll see that the posterior cannula shows the backflow. We'll now introduce our 4 millimeter 30-degree angle arthroscope into the subdeltoid bursa and take a look at the outside of his rotator cuff. It's usually very difficult to see when you first get in, so you have to debride some of the tissues. An 18-gauge needle has localized a third portal through the lateral aspect of the deltoid. A full radius resector is used to debride some of the subdeltoid bursa so we can see. We look down on the rotator cuff now and you see a full thickness tear involving the supraspinatus portion. Obviously, this was a fairly extensive lesion in this 60-year-old gentleman. We would next like to decompress his coracoacromial arch. This shows the coracoacromial ligament as it attaches to the undersurface of the acromion. A full radius resector is being used to excise the coracoacromial ligament. We're now looking up at the undersurface of the acromion. This actually is the anterior portion of the undersurface. The inflow cannula is being used to palpate that surface to demonstrate it. An arthroscopic acromioplasty is going to be performed. An arthroscopic burr is being used at this point to burr the undersurface of the acromion in the usual place where you would do open acromioplasty. Further debridement and burring of the bone is being carried out. You can see that you get a fairly good view of the undersurface of the acromion as we finish up this arthroscopic acromioplasty to decompress the coracoacromial arch in this individual. Another area of specialized interest around the shoulder is the acromioclavicular joint. recently we have been carrying out arthroscopy of the acromioclavicular joint and even doing an arthroplasty of the acromioclavicular joint arthroscopically. This shows a Major League Baseball pitcher with obvious degenerative arthritis involving his AC joint. Arthroscopy of the AC joint is carried out through two portals. One posterior superior, as seen here and defined by an 18-gauge needle, and a second anterior superior portal defined by a second 18-gauge needle. Once backflow is established, we know we're in the AC joint, then a 4mm 30-degree arthroscope is introduced through the posterior superior portal. We're now looking in this degenerated AC joint, and a small full radius resector is being used to resect the degenerated meniscus within the AC joint itself. To orient you in regards to the anatomic landmarks, the articular portion of the acromion is to your upper right, and the articulated end of the clavicle is to your lower left. The full radius resector is being used to further debride the degenerated articular cartilage on the end of the clavicle. Actually, a rather thorough decompression of the AC joint can be carried out arthroscopically. Actually, a small burr can be then introduced, and the distal end of the clavicle can be burred down, and a modified Mumford procedure can actually be performed arthroscopically.
Jim, every procedure has its complications. What have you experienced in shoulder arthroscopy?
In this series, I have at least 4 cases that had some minor complication. I had 2 ulnar nerve transient paresthesias. I had 1 musculocutaneous nerve paresthesia that was transient. And I had another case where I had done an arthroscopic subacromial bursectomy and arthroscopic acromioplasty that had a rather severe postoperative painful course. We thought for some period of time that he may have had a subclinical infection. However, all of this cleared, but the patient did have to be admitted to the hospital, and it took about 2 weeks for the clinical course to settle down.
Jim, you've certainly shown us some beautiful labral lesions. Do you believe with a tear of the labrum that you get an increase in anterior instability of the shoulder?
Jack, there's no question. Certain labral lesions are associated with instability of the shoulder, particularly anterior and inferior glenoid labrum lesions. If these labrum lesions are excised, certainly instability will ensue, even to frank anterior dislocation.
Jim, in the knee we've seen that we've gone all the way from total meniscectomy to partial meniscectomy to the repair of the meniscus, which is where we are today. Do you think we're going to see ourselves repairing torn glenoid labra?
Jack, this is certainly the ideal. It's been my hope that we'll be able to repair the labrum lesions that I've shown you today. At the present time, we're certainly working on suturing techniques that will allow us to repair these lesions and to stabilize the shoulder arthroscopically through suturing techniques. There still will certainly be some place in arthroscopic surgery of the shoulder for partial excision of labrum tears. I don't think that all labrum lesions will ultimately be repairable, but the goal will be to repair as many as possible.
Jim, can I take you into your results a little bit? You've stapled some shoulders. What do they look like?
I've been very cautious and selective about arthroscopic shoulder stapling. I've selected my patients very carefully, and I've done them in patients that did not have a very high risk. In other words, I have not really done them in those, for example, high school athletes involved in contact sports. I tried to pick the patients that had less demands in a lower risk category, and I have done arthroscopic stapling and followed these cases very carefully. The follow-up at this point is certainly very short, and I would say too short to really make any comments about long-term follow-up. So far, though, in those cases that I've selected, the arthroscopic stapling procedures have done very well. We all are wondering about the staples and whether or not they will come loose. So far, I've had none of those problems. I've had no complications with the few selective cases that I have done arthroscopic stapling on.
Those of us that do shoulder arthroscopy have seen these patients that have frayed lesions of the rotator cuff. We've seen that in debriding these lesions, these patients seem to get better. You've shown similar experiences with throwing athletes. Why do you think they get better, Jim, and what have you seen for results, and how long have they held up?
Jack, I have a series of about 45 throwing athletes who had rotator cuff debridement. As best I could determine arthroscopically, these were incomplete tears involving the undersurface of the rotator cuff, and these tears were, at least as best I can tell, associated with failure under tensile loads during the deceleration mode of the throwing act. We arthroscopically debrided these patients, and we have followed them consecutively. These patients now are all over 1 year follow-up, and the majority are over a 2-year follow-up. Our results, which are based primarily on subjective criteria with their ability to return to their previous level of throwing, have been satisfactory in 80%. We still have a 20% category that has been unsatisfactory, with them being unable to return to their previous level of throwing. I don't really know scientifically exactly why these patients get better. I would hope that the shaving of the undersurface of the rotator cuff promotes a healing response and improves the blood supply. You must realize that these athletes are put through a very intensive post-operative rehabilitation course. It generally takes them about 6 months to get back to competitive throwing. For all I know, the rehabilitation may be more important in their recovery than the arthroscopic procedure.
Finally, Jim, let's talk about rehabilitation. How do you rehabilitate the shoulder on which you've just performed an arthroscopic procedure?
This is a very essential part of the treatment protocol. We have put together a protocol that evolves around range of motion and strengthening exercises for the rotator cuff. These exercises are begun almost immediately. Certainly that's one of the advantages of the arthroscopic procedure. The first 6 weeks, these athletes are placed on the rotator cuff strengthening and range of motion exercises and are not allowed any real throwing activity. In some cases, we will begin rehabilitative type throwing at 6 weeks post-op. I would say, though, that the majority of these cases really don't start any rehabilitative throwing for about 3 months. When they begin their throwing, we put them on what we call an interval throwing program. This is a graduated throwing program which allows them to throw in intervals. The key to this program is to not allow the shoulder to get fatigued. For example, a thrower can probably throw 10 minutes at a time without pain. He certainly couldn't throw 30 minutes at one time without pain or fatigue. The interval program may allow that particular player to throw a 10-minute interval, rest 30 minutes, throw another 10-minute interval, rest 30 minutes, and another 10-minute interval, and with that, he has thrown a full total of 30 minutes, and that's without fatigue and without pain. I think that's the key to the interval throwing program, and we allow the players to progress at their own speed, depending on pain and whether or not they're experiencing soreness the next day. And if they're not, then they progress from the long toss and short toss program. We allow them to progress depending on the pain and depending on whether they're sore the next day. Generally, though, it takes them about 6 months from the time of their arthroscopic procedure to be fully rehabilitated and to be ready to go back to competitive throwing.
Thank you, Dr. Andrews. Dr. Michael Chapman will discuss intramedullary fixation of fractures of the femur. With high-velocity injuries becoming more common, fractures of the femur are a more frequent problem. What do you think the place is of intramedullary fixation in dealing with this problem, Mike?
The standard of care in the treatment of femur fractures in the United States today is treatment in traction. This is by far the safest way to treat fractures of the femur. It, however, has a lot of disadvantages. In particular, the patient is required to be in bed for a prolonged period of time. Because of this, you have a long period of hospitalization. This, of course, is quite costly. The fact that the patient is on enforced bed rest interferes with rehabilitation. Taking a look at the costs in our hospital, for example, treatment in traction costs approximately $40,000 for a given single hospitalization, whereas treatment with intramedullary nailing, which of course gets the patient out of the hospital earlier, costs only $10,000. And these costs, of course, do not take into effect at all the costs of loss of income to the patient and loss of productivity to society. Cast brace treatment, which was popularized by the military during the 60s and early 70s, has greatly improved the problems associated with traction treatment, in that it's now possible with this type of care to mobilize the patient out of bed earlier and to discharge them from the hospital a lot sooner. Cast brace treatment, however, has some problems associated with it. In a review of the literature on cast brace treatment, which I carried out about 4 years ago, in 742 fractures that had been reported on in the literature at that time, there was a malunion rate of 7%, a non-union rate of 2%, and shortening of over 2 centimeters occurred in up to 13% of the patients. Although this type of treatment is far superior to treatment in traction, even so, somewhere between 5.4 and 30% of patients, depending upon the series, did not gain knee flexion greater than 90 degrees. Because of the problems associated with non-operative care of femur fractures, operative care has become more popular. Plate fixation has become very popular in Europe. Reviewing the literature, however, on plate fixation of femoral shaft fractures, and again, this was a review of the entire English-speaking literature done approximately 3 to 4 years ago, I was able to find 498 fractures that had been reported on. The infection rate in this group of fractures, which had been internally fixed with plates, was 3.2%, which is substantial. And the reoperation rate, which is a very significant figure, was 20 to 24%. And these reoperations were generally required for loss of fixation sometime during the period of treatment, or for the treatment of non-unions by replating or bone grafting. Now, looking at the results of closed nailing, this again is a review of the English-speaking literature up to about 1983. There were 1,786 fractures that had been reported upon. In this group of fractures, the infection rate was only 0.7%. Malunion was quite rare. Non-unions occurred in only 0.2% of the patients. Knee motion of greater than 90 degrees was present in 100% of the cases where this particular factor was mentioned in the paper. Now, closed nailing, of course, is a technically challenging and somewhat difficult technique, whereas open nailing is very popular and has been around for many years, of course, having been devised by Kuntscher, in fact, prior to World War II. And one should ask, are there particular advantages of the closed technique over standard open nailing techniques? Well, again, looking at our review of the literature, there were 1,488 cases of open nailings reported during this time period as compared to 1,137 closed nailings. Looking at the incidence of deep infection in closed fractures, the incidence of infection in open nailing of closed fractures was 3.8%, and this compares to an infection rate of approximately 1% in closed nailing of closed fractures. Now, where this difference becomes more striking is when you look at open nailing of open fractures, and it was 22.2% in the open nailing group, and none have been reported, in fact, in closed nailing. Now, this is probably a distortion, as in more modern series, there have been some infections reported in closed nailing, and 22% is obviously very high using modern techniques. But even so, it points out the fact that the infection rate in open nailing is far higher than in closed nailing. Now, looking at the incidence of delayed union, this is also much higher in open nailing, in that with a rate of 3.4% in open nailing and 0.3% in closed nailings, it's about 10 times higher. And again, Looking at the non-union rate, there have been no non-unions reported in the literature in closed nailing, although it's quite obvious to all of us that they have occurred, they just simply haven't been reported on. And in the open nailing group, there was a non-union rate of 1.6%. Now, the advantages of closed nailing are probably related to the many different factors, but the main one is that it has limited surgical exposure. As seen here, the typical buttocks wound is all that is required to accomplish this nailing. As only a limited incision is required to do closed nailing, and because you do not actually expose the fracture itself, you preserve the fracture hematoma, and most importantly, you preserve the muscle and periosteal blood supply to the femur. Both of these factors enhance callus formation and therefore make it much more likely that the fracture is going to go on to union. I think that it is interference with the muscle and periosteal blood supply and evacuation of the hematoma that accounts for the increased non-union rate in open nailing. As seen in this radiograph of a femur fairly soon after closed intramedullary nailing, there is copious callus formation about the entire fracture site seen here. This type of copious callus formation is very rarely seen in open type nailings or in other types of internal fixation. Other advantages of closed intramedullary nailing are that intramedullary nailing from a biomechanical viewpoint produces a load-sharing type fixation. This takes advantage of inherent fracture stability. With load sharing, it's possible to immediately weight bear a large majority of these patients, that is, those with stable fracture patterns. This, of course, greatly enhances rehabilitation. With the fixation, it's possible to get the patient out of bed very early after surgery, and one can then go to immediate knee rehabilitation, muscle rehabilitation, and weight bearing. This opportunity for early mobilization out of bed and early rehabilitation, of course, allows for discharge of the patient from the hospital early, and this dramatically reduces the cost of hospitalization. In addition, of course, particularly for people who do sedentary work, it's possible to get them back to their occupation earlier, and this saves other costs from the standpoint of disability insurance and loss of productivity. From a long-term viewpoint, another great advantage of closed intramedullary nailing is that stress protection is basically avoided, in that when the patient's weight bearing, they bear a considerable part of the load through the shaft of the femur itself. And the nail, being an intramedullary device, does not have the stress protection problems associated with plate fixation and with the prolonged non-weight bearing required. So at the time of nail removal, one has to worry very little about the problems of refracture. Now, let's talk about indications. Basically, any femur fracture that has a suitable configuration, that is a stable configuration in adults, is a good indication for intramedullary nailing. And with now the modern interlocking techniques that have been recently introduced, it's also possible to take on comminuted and unstable patterns. Let's take a look at these different fracture patterns. Beginning here, we have a straight transverse fracture, which of course is a very stable configuration, and it's an ideal pattern for closed intramedullary nailing. The only problem with this pattern, of course, is that being a straight transverse fracture, it has somewhat more of a tendency to malrotate, so one must be careful about rotatory instability in this type of fracture. Moving on to the short oblique pattern, this is perhaps the most perfect pattern in that with the short oblique configuration, you have inherently good rotational control with an intramedullary nail. The next pattern is the short oblique or transverse pattern with a longitudinal split. Now, as long as the longitudinal split does not propagate, this is also an excellent pattern for intramedullary nailing. Greater caution is required, however, as it's possible to split out a butterfly fragment during the nailing, or of course a split can occur later, which could lead to instability. The more comminuted pattern, but with a very small butterfly fragment, is also suitable for routine intramedullary nailing. But one must be certain that there's good cortical contact over about 50% of the surface area of the fracture. This will prevent inadvertent shortening during the postoperative period. Moving on to a more comminuted pattern, that is the fracture pattern with a large butterfly fragment. Intramedullary nailing without interlocking is still possible. However, one must be much more cautious in the postoperative period to avoid shortening and rotational deformity. It's important that you have enough fracture contact at the points here that shortening is prevented, and you must remember that the longer the butterfly fragment, the more you're actually dealing with a subtrochanteric pattern here and a supracondylar pattern here, both of course which are inherently unstable. Now moving on to the next set of 4 configurations, we have here the comminuted pattern with segmental instability. This pattern is not suitable for standard closed intramedullary nailing, and interlocking techniques must be used to prevent this fracture from shortening. An alternative, if you don't want to use interlocking or that technique's not available in your hospital, would be to do a routine non-locked intramedullary nail and then simply hold the patient in traction until early fracture stability occurs, and that's usually by about 6 weeks. Using that technique and perhaps augmenting with a cast brace, you can again shorten down the hospital time and be more assured of earlier union and a more satisfactory alignment. The long oblique or spiral pattern is also suitable for routine non-locked intramedullary nailing, but again you must take precautions from the viewpoint of preventing shortening and rotational deformity. Generally speaking, it's better to use some type of static interlocking nail on this configuration. Now, up to now, we've been showing patterns that have been predominantly in the mid-diaphysis of the femur. Here we have a subtrochanteric fracture pattern. Because of the short length in the proximal fragment, these are generally not suitable for standard closed nailing techniques. One must use some type of interlocking nail, or, for example, a Zickel nail can be used as well, and we like to use that using closed technique. The comparable pattern in the distal femur is the supracondylar fracture. This fracture can be nailed with non-locked intramedullary nails using closed technique, but one must augment fixation with cast bracing to avoid angulation in this short distal fragment. This, of course, is an ideal pattern, as is the previous one, for dynamic type interlocking nailing, where one uses the interlocking screw only in the short fragment. With that type of fixation, often immediate weight bearing is possible. Now moving to the segmental fracture as depicted here, this is an ideal pattern for standard closed IM nailing techniques, as long as the fracture pattern at either end of the segmental piece is of a stable configuration. If the fracture patterns at either end are not stable, then again going to interlocking nailing is a great advantage. How about contraindications? Well, generally speaking, we do not nail fractures in children. The adolescent is a more controversial age group, and we'll be talking about that a little bit later in this presentation. The possible exception in children is the child with multiple injuries whose life is threatened by the difficulties of prolonged bed rest that are frequently imposed by treatment of femur fractures, and there is perhaps an occasional child with serious polytrauma who has life-threatening injuries that we might consider closed nailing in early. But since these children do so well with standard closed techniques, generally we do not do intramedullary nailing on children's fractures. Concomitant infection elsewhere in the body, or more serious concern in the region of the intramedullary nailing, is of course a contraindication to this technique. Special indications for closed intramedullary nailing techniques are the treatment of non-unions of the femur, malunions, and there are circumstances under which leg length equalization can be done using closed technique for shortenings and, on rare circumstances, lengthenings. We're going to concentrate, however, in this discussion on the treatment of fresh fractures, so we won't be commenting on these special indications. Now, let's talk about the technique that I prefer for closed intramedullary nailing, and that is the lateral decubitus technique. In the lateral decubitus technique, it's important to use a fracture table that is compatible with the fluoroscope. In our technique, we use a tibial pin traction holding device that provides absolute control over the extremity. In addition to that, you'll notice that it's not necessary to support the leg below the knee. This allows the knee to flex freely during the case and takes tension off the sciatic nerve. The down leg is placed on this leg holding device that you see here. This leg can be brought in very, very close to the upper leg and allows the fluoroscope to pass around the leg more easily. We secure the leg to the leg board with a wrap. The patient's position on the table is determined by the vertical frontal perineal post, just barely seen on the videotape here by my hand. Connected to this is a perineal post through the groin, seen here. The position of the patient is determined by placing this post directly in front of the anterior superior iliac spine. The upper extremity is attached to an airplane splint, and this is secured in such a way that the position of the torso is fixed during the procedure. This prevents malrotation. The ideal position for reducing the vast majority of fractures is with the leg in neutral abduction and the limb parallel to the floor, with the hip flexed approximately 20 degrees. The limb, if anything, can be slightly abducted to take tension off the iliotibial band, but you should avoid adduction. You'll notice that the thigh is quite loose here. That enhances the ability to manipulate the proximal fragment. We use very little traction. This, of course, requires that the femur be out to length preoperatively. A concern is gravity sag at the fracture site. This can be avoided by simply positioning the tibial pin traction device to lift the distal fragment so that it is parallel to the floor. And you'll notice that after securing it, as seen here, that when I let go, the distal fragment will remain parallel to the floor, and we have no gravity sag at the fracture site. The limb, as far as rotation is concerned, in the lateral decubitus position, should be placed in approximately 20 degrees of internal rotation. Now the C-arm should be positioned so that it is at right angles to the femur. And this is with the C-arm in position for the lateral view, and of course you'll note that it's brought in from the anterior side of the patient. The C-arm should be placed so that it can be swung easily from the hip to the knee without repositioning the main body of the machine. You want to have the C-arm positioned so that you can roll from the lateral to the antero-posterior direction with ease. You'll notice that because we have the two legs fairly close together, this is easily accomplished. Again, the machine should be positioned so that on this view you can also see from a full AP of the hip to a full AP of the knee. Now going to our first fluoroscope image, you'll notice that we've placed a safety pin on the scope head so that we can tell what is dorsal and what is ventral. And you'll notice that on the lateral view we already have a perfect reduction because of the position we've placed the femur. This is the distal fragment, and then this is the proximal fragment below. Now moving to the lateral view, you'll note that the proximal fragment is in a flexed position, which is fairly standard. Our safety pin is dorsal. And all that is needed to reduce this fracture now is to take the proximal fragment and manipulate it into alignment with the distal fragment, which is in a neutral position because of where we place the limb. And you'll notice here with our pointer, all we have to do is move that fragment up in line and we'll be ready to drop in a guide pin. Now moving to the prep and the drape. We prep out normally the entire limb, although of course our incision will be limited to the hip itself. I prefer to drape with just sheets, as excessive draping materials make it difficult to move the C-arm under the drapes. Currently, we fix these to the patient with staples and then secure the drapes with a steri-drape. This avoids the use of any radio-opaque instruments in the draping, which would interfere with the function of the fluoroscope. The incision is placed in the buttocks beginning from the tip of the greater trochanter, extending proximalward in the line of the fibers of the gluteus maximus. Here the incision is being made from the tip of the greater trochanter, as I mentioned, in line with the fibers of the gluteus maximus. Dissection is carried sharply through the subcutaneous tissue and directly down to the deep fascia of the gluteus maximus, which is also incised. It's then possible to use blunt dissection with either a finger or a pair of scissors to split the fibers of the gluteus maximus. Once the greater trochanter has been exposed by reflecting the gluteus medius superiorly, it's then possible to place the middle finger beneath the tip of the trochanter and feel for the quadrate tubercle, which leads one's fingertip into the piriformis fossa. You'll notice that this is a blind technique. After feeling the fossa, one slides the finger back, places the awl on the tip of the finger, and then pushes the awl up into the underside of the greater trochanter where it connects with the base of the femoral neck. It's important to enter on the underside of the greater trochanter rather than actually on the top of the femoral neck. With the awl, it's possible to feel anteriorly and posteriorly prior to making penetration to be certain that you're dead center in the top of the neck. This is perhaps one of the most critical aspects of the technique, is the entry point, which must be absolutely directly above the femoral canal. Once the surgeon is certain that he has located the proper entry site, the awl can then be twisted to perforate the underside of the greater trochanter in the piriformis fossa. The next step is to be certain that the entry point is in the correct position. This is done by taking a sharp, medium diameter flagged guide pin and inserting it into the entry hole after withdrawal of the awl. The pin is placed in position and then driven through the cancellous bone of the proximal femur with a mallet. It should be brought down into the proximal fragment so that it can be viewed on the fluoroscope. On this lateral image on the fluoroscope, you'll note that the guide pin is well centered in the proximal fragment. It has extended beyond the fracture site, but of course that's not intended with this guide pin. Now on the AP view, you will also note that the guide pin is well centered, indicating that our entry site in the proximal fragment is correct. Next, we take a hollow reamer, place it over the flagged guide pin, and then using it like you would a brace and bit, enlarge the entry hole to the femur. The flagged guide pin can then be removed and the guide pin assembly placed into the proximal fragment. We use a 3.5 millimeter flexible guide pin which will serve for reaming. Attached to it is a T-wrench for controlling the guide pin. Over the flexible guide pin, we place a 52 centimeter by 11 millimeter Kuncher nail, which will be used to manipulate the fracture site. This guide pin, of course, being a reaming guide pin, has a ball tip on it. It's now inserted through the center of the hollow reamer into the proximal fragment. One should be certain, of course, that it is inside the canal of the femur. The K-nail is slid into place and the hollow reamer is then removed. This rod need only be placed by hand and not malleted into position. Now the surgeon can use the Kuncher nail in the proximal fragment to control and manipulate the proximal fragment. And this allows easy reduction of the fracture. On this lateral fluoroscopic image, you'll note that the guide pin is just proximal to the fracture. Normally we don't use live fluoroscopy, but here for demonstration purposes we show you how the fracture can be manipulated. The guide pin is placed in perfect position on the AP view, then in perfect position on the lateral view, and then it can be driven across the fracture site into the distal fragment down to the physeal line at the knee, which is the normal length used for most rods. With the guide pin in this position, one can then measure for rod length. This need not be determined preoperatively as long as one has a full selection of intramedullary nails available. A second guide pin of similar length is placed at the tip of the greater trochanter, lined up with the guide pin which is in the femur, marked with a Coker clamp, and then taken to the back table where the appropriately sized rod can be selected. We can now proceed with reaming. The T-wrench is removed, and we begin with a 9.5 millimeter end cutting reamer, which is placed over the reaming guide pin, slid into the femur, and reaming is initiated. Once the 9 millimeter reamer has been driven, one should then proceed with reaming in 1/2 millimeter increments. In some cases where the surgeon is adequately experienced with the technique, it is possible to go up in 1 millimeter increments, but the safest is to use 1/2 millimeter intervals. The one problem associated with reaming is that it's possible to inadvertently back the guide pin out as the reamer is withdrawn. So an assistant should take a lap tape and hold the guide pin in place as the reamer is withdrawn. Here we're moving up to our next size reamer and progressing with reaming. It's not necessary to visualize reaming on the fluoroscope. One simply reams the length of the isthmus of the medullary canal. But again, for demonstration purposes, we show you this procedure on live fluoroscopy. The reamer size relative to nail size depends upon the particular brand of reamer and nail used in your institution. In our institution, we've found that reaming to size, that is, for example, a 15 millimeter reamer for a 15 millimeter rod, works well. After reaming, the reaming materials are irrigated and cleansed from the hip wound, and we select the appropriately sized nail for driving. You'll note that we use a pre-bent nail, and this nail has a bullet nose tip. This bullet nose tip allows the rod to follow the guide pin, and it's less likely to impinge on the distal fragment during driving. The nail is placed over the guide pin. The slot is placed directly anteriorly. The rod is driven with a tuning fork type mallet into the proximal fragment. It's important that the surgeon visualize the fracture site on the scope during the drive so that the nail moves smoothly into the distal fragment. You'll note here on the fluoroscope that the nail is entering the distal fragment in a very nice fashion. You'll notice slight distraction in the fracture site, and it's important to remove the traction at this stage so that the fracture impacts during the drive. Live fluoroscopy need not be used during this either. We then switch to a female-style driver and drive the rod further down into the distal fragment. You can see it entering across the fracture site here. You'll note that the fracture is slightly distracted. It's important to remove the traction and allow the fracture to impact during this portion of the nailing. We drive further, and then the guide pin is removed, and then the nail is driven home with the male-style driver, as seen here. This is easier on the soft tissues as the nail is driven home. On this final fluoroscopic view, you'll note that there's still slight distraction at the fracture site. Impaction of the fracture site is important as this increases the friction between the bone fragments, which is important to rotational control post-operatively. Supine nailing techniques are also quite popular in the United States. This technique is most useful when you have fracture tables which are not really very suitable for the lateral decubitus technique. A lot of surgeons prefer the supine technique as the positioning is very similar, of course, to that used for routine hip fractures, which is a position to which most surgeons are accustomed. This is particularly important if you don't do a large number of closed nailings. The patient is positioned in the standard supine position. A traction pin seen here can be used to augment the pull on the foot, and by tying the traction pin to the foot holder, you produce some flexion in the knee which prevents tension on the sciatic nerve. You'll note that from this viewpoint that the leg has been placed in adduction. This is important to allow adequate access of the surgical instruments at the hip. This is after the procedure has begun, and you'll note that one of the disadvantages of this technique is that the surgical instruments at the hip do pass rather closely to the leg. This is why I prefer the lateral decubitus technique, which places the surgical instruments well away from the patient. The difficulty with this technique is that if one is not careful, the entry site will be placed too far laterally on the tip of the greater trochanter. This will drive both your reaming instruments and the rod into a medial position in the proximal fragment. This produces malposition and comminution in the medial distal region of the proximal fragment. It's because of this disadvantage that I prefer the lateral decubitus technique. Now let's talk about the post-operative management of patients who have undergone closed nailing. Post-operatively, in order to allow the patient up weight-bearing immediately, it's nice to apply a knee immobilizer as seen here. Often these patients have difficulty with quadriceps control primarily because of pain in the fracture site, and this aids the patient in getting up immediately. The knee immobilizer can usually be abandoned within a few days as soon as the patient gains quadriceps control. In those fractures where you're concerned about rotational control, an anti-rotation splint, as seen here, can be applied to the foot whenever the patient is sitting or lying in bed. It can be abandoned, of course, when the patient is up walking. And we forbid these patients to lay on their abdomen, which of course produces external rotation in the distal fragment. This is necessary for about the first 4 weeks. After that time, most of the patients have enough healing that rotational control is present. The typical post-operative course is that the patient can be out of bed within 1 to 3 days. We encourage our patients, of course, to be at a minimum up in a chair at bedside on the first post-operative day. But this is dependent upon the presence of other injuries and the amount of pain that the patient has. The vast majority of patients are partial weight-bearing with crutches by 7 days after injury, and this is about the normal time for discharge after a single isolated femur fracture. The average patient will be full weight-bearing with a cane, that is in stable configurations, by 6 weeks after fracture, and most will be walking without any assistive device by 8 weeks after injury. We have not addressed the problem of the open fracture of the femur, and this bears discussion, as the risk of infection is greater when carrying out intramedullary nailing of open fractures. Indications for acute nailing of open fractures of the femur are patients with polytrauma who have life-threatening injuries. Another good indication is the patient who has a floating knee, where management, that is immediate management of the fracture, requires good control of the femur fracture. If you're dealing with situations where limb salvage is of great concern, then acute nailing of the open fracture may also be justified. Acute nailing is safest in type 1 open fractures and in mild type 2. In type 3 open fractures, we usually use external fixation rather than nailing because of the risk of infection. The strongest indication for immediate nailing of an open fracture is the presence of life-threatening multi-system injuries. The preferred technique for open fractures is to carry out nailing on a delayed basis. Initially, the wound is irrigated and debrided and then left open. The femur fracture is stabilized and kept out to length by placing the patient in skeletal traction. On rare occasions in the polytrauma patient, you may want to externally fix the fracture rather than place the patient in traction. If this is done, removal of the external fixation pins must be done a number of days before the closed nailing to allow the pin tracks to close. In the situation where the patient is in traction, delayed closure of the wound is carried out at approximately 5 days post-injury or whenever the wound is in optimal condition for closure. After a delay of approximately 5 to 7 more days, and also when the wound is clean, of course, closed nailing can then be carried out. At the time of that nailing, it's important to culture the fracture site, that is, you can culture the remines, and to use systemic antibiotics to minimize the risk of infection. Avoiding pitfalls and complications in closed nailing obviously is quite important. Inability to achieve fracture reduction is perhaps the most common problem that surgeons undertaking this technique have. The major cause of this is overriding of the fracture fragments at the time the patient's brought to surgery. It's extremely important to have these fractures out to length prior to surgery. This usually requires traction heavier than you're accustomed to using. For example, in the average male, traction up to 35 pounds may be necessary to get the fracture out to length, and if you're absolutely certain that closed nailing will be done, perhaps even distract the fracture slightly. I have already discussed the positioning of the fractured limb on the fracture table, but I'd like to re-emphasize that the fractured limb should be placed parallel to the floor and perhaps even in very slight abduction. It's flexed 20 degrees at the hip, and the extremity is placed distally in 20 degrees of internal rotation. This is emphasized on this drawing, which shows that if the limb is adducted, tension is placed on the iliotibial band. This relatively shortens the thigh, which forces the fracture site into a fixed valgus position. This makes manipulation of the fracture quite difficult. The correct position is to place the limb in a neutral position. This removes tension from the iliotibial band, allows the distal fragment to assume a neutral position, and makes it very easy to manipulate the proximal fragment into alignment with the distal fragment. Again, I've shown you the technique of manipulation of the proximal fragment with a Kuncher nail in the fragment, and in this drawing I'd like to again re-emphasize that with a nice long Kuncher nail, a long lever arm is achieved which allows easy manipulation of the proximal fragment. This allows one to bring the proximal fragment easily into alignment with the distal fragment. Other problems in these fractures are comminution, and this can occur intraoperatively, shortening, and malrotation. The most common cause of comminution is improper entry into the proximal fragment. So this drawing re-emphasizes the proper entry point. You'll note here that the awl is entering the piriformis fossa in the soft cancellous bone on the underside of the greater trochanter, just off the base of the neck of the femur. This produces an entry point which is directly in line with the intramedullary canal of the femur. A common mistake is to enter on the tip of the greater trochanter, which is actually too lateral and not in line with the intramedullary canal. Other causes of comminution intraoperatively are unrecognized cracks. These, of course, are difficult to avoid. Really good x-rays preoperatively on 4 views will help pick these up. But one must be prepared to solve these problems intraoperatively if a crack does occur. Unstable fracture patterns, of course, also can lead to instability. And then if you have a patient who is non-compliant with the particular recommended weight-bearing program, problems can also be encountered. The solution to most of these problems is the use of interlocking nails. Interlocking nails are very quickly becoming the state-of-the-art in intramedullary nailing. There are many new interlocking nails on the market. Most are excellent, but the majority of them have new interlocking systems, and most of these interlocking systems have a few problems. I'd like to bring to you briefly our experience with the Grosse-Kempf interlocking nail system. This is a clinical study which was updated in December 1984. It was conducted at these centers throughout the United States. The number of femur fractures in this series is 168, with a follow-up at the time of this data collection of approximately 4 to 22 months. In this group of 168 patients, we had very few complications. These included 3 infections, 2 of these cleared after bone healing and removal of the implant, a broken nail, and 1 case in which we had some discomfort at the nail tip. The proximal cross-locking systems present very few problems in most nails. The distal cross-locking systems, however, are problematic in most nail systems in spite of the new cross-locking guide systems available. For example, this guide system used for distal locking we have abandoned as we've found the freehand technique to work much better and to be more rapid and accurate. This technique is performed by first aligning the fluoroscope with the distal cross holes in the rod. This is done in such a way that the hole that one is going to cross-lock is placed in the center of the fluoroscope screen and then aligned so that the hole in the rod is perfectly round and the hole on both sides of the rod is perfectly superimposed, as seen here. One then makes a small incision over the entry site, and an awl is then brought in from the side. It's important to keep the surgeon's hand, of course, out of the main beam of the fluoroscope. The tip of the awl is placed directly in the center of the hole of the rod, as seen in this illustration, and then tipped up into the vertical position and used to make a pilot hole in the side of the femur. With this pilot hole present, it is then possible to align a drill with the C-arm and drill across the 2 holes of the rod and place the cross screws. After placement of the cross screws, of course, on the lateral view, one no longer sees the holes, indicating that the cross screws are in perfect position. Now let's look at the results of closed intramedullary nailing. The most recent, and I believe the largest series reported in the literature in the last 10 years, is that of Winquist, Hansen, and Clausen from Seattle, published in the Journal of Bone and Joint Surgery in 1984. In their 520 cases, they had a union rate of 99%, an infection rate of less than 1%, shortening of more than 2 centimeters occurred in only 2% of their patients, and malrotation of more than 20 degrees occurred in only 2.3%. These are truly excellent results, particularly when compared to plating or non-operative methods of treatment. This is my own series done with my associates at San Francisco General Hospital. This series was conducted from 1973 through 1979. 223 patients were reviewed, and 186 fractures in 180 patients were in the final series. There was an average age of 29, and as you would expect, the majority were males. Our intraoperative problems were comminution in 12 patients. The predisposing factors were overriding preoperatively and longitudinal cracks, as already discussed. 3 of these 12 patients required reoperation for these complications, but a satisfactory outcome was achieved. We had very few systemic complications. In fact, we had no incidence of adult respiratory distress syndrome, no fat emboli, no thromboembolic phenomenon, and no deaths. There was 1 case in which infection occurred, and this occurred late in an intravenous drug abuser. We had no non-unions, and only 6 patients had shortening greater than 2 centimeters. We did delayed closed nailing of open fractures in 49 patients. In that group, we had 1 infection for an infection rate of 2%, and there were no non-unions. No patient in this series had less than 90 degrees of knee flexion, and this included a large number of patients who had knee injuries and associated tibial fractures. Some patients had minor hip symptoms until their nails were removed. In conclusion, I feel that closed intramedullary nailing is the treatment of choice in the vast majority of fractures of the femoral shaft. It is a technically exacting technique, but it has a low rate of complications, allows early rehabilitation of the patient. This leads to short hospitalization. Few late problems are encountered, and all of this culminates in a lower cost to the patient, which in today's society is becoming increasingly important.
Mike, occasionally we run into patients that have a fracture of the femoral shaft with an ipsilateral hip fracture. How do you manage this problem?
Jack, that's a really tough one, and I don't think there's any set given answer for that particular problem. Without question, the most important aspect of that injury is the hip fracture, which most frequently is an intracapsular fracture. So I think the surgeon should direct his initial efforts at internal fixation of the hip fracture itself. Then one can use whatever techniques are most compatible with whatever fixation was used at the hip. In most surgeons' hands, they will be using either multiple pins or a compression hip screw for the hip. And then if they choose to internally fix the femur, will most likely be plating it because rod fixation is simply not possible in the presence of those two fixation devices. It's occasionally possible with multiple pins, but it's not very easy. There are other alternatives, such as combining multiple pins or screws with an intramedullary nail, use of ender pins, and other techniques, but none of these are very easy.
Mike, you mentioned that you don't like to do a closed intramedullary nailing in the face of an open epiphysis. Is there any exception to this, particularly with an adolescent?
Well, Jack, we do nail fractures in adolescents, but we nail those adolescents who are nearing adulthood. So if the physis is open and we expect less than about 1.5 to 2 centimeters of growth total in both physes, then we'll generally go ahead and carry out a closed nailing. I should mention that in closed nailing, the proximal entry site, of course, does not cross the epiphysis of the femur proximally, and you can keep the nail short of the distal epiphysis. So in actuality, there's no reason why premature closure of a physis should occur after closed nailing of the femur. Now, in the polytrauma patient, we become more aggressive. So in some older children who have severe polytrauma and life-threatening injuries, where mobilization justifies surgical intervention in the femur, we will do a closed nailing. But these circumstances are rare.
When you place an intramedullary nail in a fractured femur, Mike, is the biomechanical stress of weight bearing on the implant or on the femoral shaft?
Well, the nail, as I mentioned, is a load-sharing device. What this means is that it's sort of like a shish kebab. The nail basically keeps the fracture fragments aligned, but all the weight-bearing forces go through, or let's say the majority of the weight-bearing forces go through the femoral shaft itself. So it's the bone that bears the weight rather than the nail. And that's why I think mechanically closed nailing is such a successful procedure. Of course, the fracture site must be inherently stable if you're going to do early weight bearing.
You alluded to the use of the interlocking nail in the treatment of femoral shaft fractures. This certainly is gaining in popularity and with some controversy. When do you remove the interlocking screws, Mike?
Well, you know, interlocking nailing is, although well developed at this stage, I think still somewhat in its infancy, in that the fixation devices available to us now are quite varied in their configuration, and the cross-locking mechanisms, I think, need a little bit more development. But in our hands, using the Gross-Kempf nail, we've found the cross-locking system to be quite good. We have found that weight bearing with static cross-locking present, that is, cross screws both proximally and distally, is inadvisable, as fatigue fracture of the cross screws or the rod will occur. For that reason, as long as the femur is statically locked, we do not allow the patient to weight bear. We tell them to touchdown weight bear. We do allow early rehabilitation of joints and muscles. After good callus forms at the fracture site and we feel that longitudinal, axial, and rotatory stability is present, then we will remove the distal cross screws to so-called dynamize the nail. And at that point, you can then allow the patient to begin weight bearing. And this is generally, in most patients, around 12 weeks.
Thank you, Dr. Chapman.